Hello, everybody. Thank you for joining us today for this Stroke ISIG's webinar, part of a series of webinars produced by ACRM and the ACRM Stroke ISIG to help bring needed information to rehabilitation researchers and providers. Today, before we get started with the presentation, I do want to advise you that this meeting is being recorded, and I'd like to ask all attendees to keep your phones and mics muted and keep your cameras turned off throughout the presentation. We do expect to have about 20 minutes available for discussion at the end of the webinar. So if you have any questions, you can you can type them in the chat feature, and we'll address as many of those as we can during the later part of the hour. So I would like to introduce Dr. Tim Dionne. Dr. Dionne earned his Master's of Science in Occupational Therapy at the University of Buffalo in 2010, and then worked at the Rehabilitation Institute of Chicago, now the Shirley Ryan Ability Lab, for 5 years, specializing in adult neurorehabilitation. He then completed the Rehabilitation Science PhD program at the University of Buffalo in 2019, and his current research are in knowledge translation and dissemination, evidence-based practice, telehealth, AI, and implementation science. He teaches neuroanatomy and applied neuro courses at the University of Buffalo. So we are really excited to have him here today to present to us, talking about stroke and virtual and technology-based practice. So I am going to fully hand the mic over to you, and we look forward to this presentation. And I ask that everybody, if you have questions, again, just save them until the end.
All right. Well, thank you, Susie, for that introduction. I appreciate it. Let's get started here. Stuff that I'm going to talk about today is stuff that I've done over time throughout my research career, and also a lot of personal interest and tech things that I've learned along the way. I'm just going to make some disclosures: no financial interests at all in any of these activities, except the fact that I'm employed by the University of New Mexico. And then our study was funded by NIGMS under that award. So here are some of the outcomes that we're going to talk about today, the objectives. We're going to explore technological innovations. We'll talk about the latest advancements in things like AI-driven tools, virtual treatment platforms, designed to promote and to provide remote therapy. We'll talk about some examples, and then evaluate practical applications, like, well, how well do they work, and whether or not there's something valuable to be learned out of it. And then different methods to collaborate in a virtual setting and support each other throughout our various research or clinical interests. So here's kind of what we're going to talk about, the outline. We're going to talk about access limitations, different types of tech solutions, and there's some examples, and then kind of some overview of research and next steps. Okay, so how do we engage our stroke patients with various technology, new advancements in technology, when there's so many challenges that they face just engaging in their normal life after a stroke? That's a good question. So some of the challenges that they face could be the availability of expert clinicians. So is there someone who understands stroke rehab in the way that they need at the time where they are? And so if so, like, how far do they have to go to get it? Is that a limitation? And then do the patient, client, or subject, are they available to take time off of work or their life or the other obligations? And then can the patient or client or subject afford to engage in the treatment or research based on their life situation? So these are just some of the challenges facing folks who have experienced stroke in terms of getting treatment or participating in research studies. So one of the key ones is availability of experts. So in New Mexico, there may not be an expert clinician available right when the person needs it, where the person needs it. And sometimes when someone does exist, there's waiting lists or other issues that face the client in terms of getting care. And that can have a really huge impact on recovery. And so, and in general, there's a lack of capacity in places like New Mexico or elsewhere where there may be just some challenges getting that expertise right where it needs to be. So, and also we have eager clinicians, and this is based on some research that I've done here in New Mexico. We've got clinicians dying to have the information, become the expert, but how do they gain that knowledge and that confidence to apply that information and clinical skills in the right way so that they can say, hey, I'm an expert in stroke, because that's what we need, right? To build that capacity. So clients also are experiencing these like time drains in terms of personal obligations, professional obligations, and financial obligations in terms of like, well, can they get the equipment? Will they be able to get a ride? Do I need to watch my grandchild? And I also need to go to therapy. These are the things, or you know, a 5-hour research study that requires 5 hours of their time. And in general, we're finding a lot of challenges when it comes to support services, institutional support services. There's this lack of structural support that helps these folks manage these obligations. And so this is where I intended to ask, what are some other barriers of care to the audience that they see? And I'm sure I'm missing some, but because I can't be completely comprehensive, every place is a little different. But just thinking about, well, how do I get my care or my intervention that I'm studying to my clinician in a way that's effective, that works for both us and them, and there's lots out there. So technology can be one of those bridges to bridge that gap, that geographic distance, that time, the money, in terms of getting access of care to the people who need it, and or participation in research. So the slides kept changing my font size for some reason anyway. So some examples of technology that I've used and have worked with includes the use of mHealth. And so mHealth and ecological momentary analysis, both of these are app-based data collection methods in terms of gathering information. The mHealth also includes intervention in terms of the platform in which it's delivered. But they also both gather data. Ecological momentary analysis is the concept of an app-based, web-based platform that has a notification that pops up and says, "Hey, it's time for this data point collection." It's like, what are you, for example, like, what are you doing right now? Are you utilizing the strategies that you learned in this intervention? How much has it helped, et cetera? Questions, it's like, how are you feeling right now? Any kind of data point that you could think of that could be measured in the moment. And so that's pretty interesting because, in the context of providing a virtual, any intervention, whether it's virtual or in person, that missing piece for research can often be like, well, where do they use the strategies? How do they use the strategies? Because they're not doing it in the clinic or in the lab, they're doing it in the real world. And so that's why this data method's so powerful, or data collection method so powerful, because it can capture information while the person's in their home environment, and it provides more realistic feedback and data. It can also be helpful and reinforce the use of strategies or whatever the intervention is, because it reminds the patient, hey, or the client or the subject, hey, it's time to do the thing that you were taught. And so that can be helpful also. And then so the other obvious one that we've really all been exposed to, and we've been exposed to it because we're here on this virtual platform doing this exact thing where we could maybe in the past been in person having this conversation, And so, or watching it recorded. These are post-COVID inspired treatment approaches. What can we do? What technology advances are current enough that are easy enough to use to provide intervention or support to the stroke population. So also the telehealth therapy, you know, most of the studies that are being looked at these recently, the ones that in my world, revolve around a virtually delivered intervention. And so I recently got to speak with the executive director at AOTA, and that was one of the things that they're really pushing because of the rules of reimbursement from COVID is expiring at the end of the year. At least OT won't be allowed to bill telehealth billing unless we get it extended, and or research is showing that we can do our treatments virtually. And so I think it's a big push, and I advocate it to everyone to try to deliver understanding and knowing that not every intervention works virtually, but knowing, well, how can we adapt it? Do we change it, the approach? And there could be a lot of opportunity in different disciplines like ours to provide that intervention. So it's kind of exciting because there's this new, it's almost like a very innovative time in terms of, well, how can we test these virtual interventions and are they effective? And what parts of it and what aspects of those interventions need to be changed than when in person, because in person there's a lot of connection and contact that can't really be reproduced virtually. And so understanding that is really important. So here's some examples of studies that I've done with data collection and intervention virtually. So running a virtual focus group, we can record and transcribe the recording very easily to be analyzed, and that can be very helpful. I think a lot of folks who aren't used to using this platform like Zoom to have any interaction, it takes a little bit for folks to warm up to it, and especially an older population, especially after a stroke. I think last ISIG Happy Hour, the speaker talked about an aphasia support group that was over Zoom. That just sounded fantastic. And so the idea of using Zoom as a platform to support folks who have aphasia is just fascinating because of the interaction, just thinking about it. I wonder, I'm assuming it's super powerful to have that experience to interact with others who have also had this, thing happen to them, whatever it was, a stroke, but have aphasia. But then also the challenge and the practice of expressing themselves virtually, I bet was a bit of a learning curve and pretty interesting to watch, I'm sure. And so things like that can be really powerful, a way to reach folks, all around the world, depending on the time. So if you want to gather a group of experts to write and create a material, there are methods to do that virtually. And so that the second row is talking about a study that I did where I wanted to create a manual on an intervention that wasn't necessarily evidence-based, more practice-based, and being done, but not being rooted in evidence or best practice. And so getting experts together to use the Delphi method to process and write something and refine it virtually, which was very successful, a very interesting way to do it, to see everyone's feedback and notes over time and the iterations improve the document. Another, in general, just virtual interventions to bring to the people to where they are. So, where they're living at home, in the community, instead of asking them to come into the clinic, just providing the intervention virtually. And so, which has been pretty powerful because we're able to interact and provide interventions to these people who may not have otherwise participated in the study. And I mean, a lot of infrastructure needs to exist for it to work. And so that you need to take that in consideration. But sometimes with studies, you can provide like a tablet or a device if the person doesn't have a personal device to use, which is important because otherwise it wouldn't work, but it's need to be considered. All right. I'm not used to not having feedback during these kinds of talks. So I wanted the next slide, I'm going to talk about the CHAMP study that Dr. Burns and I have worked on. And I want to go through some of the details and talk about the technology use during the study. And so the CHAMP stands for Cognitive Strategies for Improving Health Outcomes and Managing Risk Post-Stroke. So basically, we provided this coaching style OT intervention using this goal, plan, do, check educational framework for coming up with cognitive strategies. So it's roughly based on the co-op model, which is an OT intervention model for having the client or the patient self-generate goals. And so we did it with stroke, people who've experienced stroke, who through the screening process, who had executive dysfunction and other cognitive deficits. And so the idea was to provide this education to reduce the risk of stroke virtually and also identify goals around their life that they could work on using these self-identified strategies. Really great way to provide support for people with executive dysfunction and coming up with different tips and tricks that they used. And oftentimes the subjects themselves came up with the solutions. And we just gave them the structure to identify whether or not it was successful. And so we did baseline testing, some of which was virtual, some of it was in person. And so here's some examples of the in-person ones we did, and including some different risks. So a screening for cardiovascular risk and neurological or dementia risk. And so then the virtual outcomes that we used included the COPM, the Canadian Occupational Performance Measure, the PROMIS NeuroQual, and the daily activity log, just some examples of ones that we used during the intervention virtually. And so this was a pilot study to see whether or not we could expand it on a larger scale. And again, our goal for our study, our intervention, was to prevent recurrent stroke in people who are at risk. And so we have some foreseen changes to help with the study for the next step. But 10 virtual sessions that were conducted, an intro and a conclusion session, and then 8 sessions that included education on Life's Essential 8, which is this this goal, plan, do, check cognitive strategies. And I can definitely talk more if there are questions at the end about that. So here's just some example goals. Again, these were all done and identified virtually through therapy sessions. So some folks wanted to eat healthier. One person wanted to eat healthier and follow a diabetic diet, better manage medications, move and exercise more, go fishing again, not to forget to buy things at the grocery store. I get that one. Play cornhole and shuffleboard better. Love these goals. These are great goals, super important because they self-generated them. These were ones that they identified, hey, this is a problem I'm facing, and how do we approach that? And so we've got some feasibility data. Our retention rate was fairly high. Reasons for non-adherence included things like memory deficits, the person forgetting the session, the time. We had reminders and also, and things like health issues that popped up here and there. Our fidelity was fairly high, so the interventionist reported the intervention delivered as intended. And then the suitability measures were it's in process. Some of this data was analyzed while we had still one person doing the study. So our next steps with this is we want to make it fully virtual. And so the challenge with that is identifying how we're going to use our neuropsych baseline testing measures that we used virtually. So how do we get it from, because we did them in person, and how do we make it virtual? One of the challenges that we saw was retention in terms of keeping people in the study because of some technology issue. And so ironing those issues out and identifying what issues there are were super important. And that we've definitely learned some lessons from that. Address accessibility issues, and this relates to the technology and also just the flexibility in terms of getting the intervention to the client. And I think that we were fairly successful, but just making it more accessible is important. We also want to include nursing, the nursing discipline in the study to collect things like physiological data. We were using proxy measures in terms of cardiovascular and blood pressure and like A1C and things like that. And then the next one, family, we want to integrate those who may be at risk into the study. So when I mentioned earlier, we were targeting people who are at risk for stroke. This was people who've experienced a stroke. And then for this next step, we want to include a family member who is related genetically to the person who's had a stroke to provide education to promote this prevention of an initial stroke. And then we also want to include imaging and other specific outcome measures. Again, some of those won't be able to do virtually, but having the more high fidelity measures is really important. Okay, so that's the CHAMP study before I move on. And so the idea was that we provided the intervention virtually and really focused on accessing people who maybe couldn't physically get to due to geographic limitations, due to accessibility limitations, due to just the nature of their life. Okay, so another piece of hot topic technology, this segue is really awkward, but artificial intelligence, AI. So, we're seeing it a lot everywhere right now. And so just so you have a basic understanding, I just kind of wanted to talk about what it is. It's using these algorithms like natural language model and large language model. They're basically modeling, statistically what words can occur before and after the statement, and it can just generate these large paragraphs of data and information pulling from lots of sources. You can do things with the large language model like teach it to follow certain principles and follow certain rules and gather data from certain sources and things like that. So there's some interesting applications happening, but they can be both good and bad. And I think that's saying with every new advance in technology, the good applications, I think the next slide's on the good applications, but just thinking in general, like, well, how can we use, how can we make our note writing more efficient and maybe have more clarity? Or how can we promote the use of technology to make our life a little bit easier or something along those lines. Some of the bad applications are, I think, mostly in the context of people who are maybe novices to the content that they're using the models for. So things like college students using it to write papers, high school students using it to write papers. I think my personal perspective on that aspect is that you need to learn how to write before you can judge how the writing is. So students at that like young stage, early stage of writing and like putting thoughts on paper, it's really helpful to actually do it yourself or use the AI model maybe to rate and judge what you've written or provide context in terms of like, well, how does my writing compare to this AI's model's writing, which is basically using, the median average of every writing that exists or what taught the model. So, it may not be great, but it should be legible and understandable and comprehensive. And so a new student could create a prompt to make a paper and then judge the paper and edit it and see it as an example. But the bad actors or people acting in bad faith could just take the writing of the AI and submit it, which I think is every educator's fear. But I think there's a lot of really interesting things to be learned about the process of that writing that will be part of the education. And that's just one example of using it at like a undergraduate or high school level. There's lots of examples. I think the one that's in our news right now here in Albuquerque is the Balloon Fiesta is coming up, and a handful of the art from posters for the Balloon Fiesta this year was AI generated. And so, which isn't great because one of the pride of the festival are these great art pieces done by local artists. And it's really important to showcase that artwork. And so like that's not great. Like if we wanted AI generated images, that's one thing, but if we want to celebrate local artists, that's what we should do. So that's just I saw that on the news recently and thought it was interesting. Um, yeah, another news article that I saw around like today around AI, was their AI assistants popping up everywhere. Integrated in Microsoft, integrated in Word, integrated in Adobe software. But there was a study on computer programmers using AI assistants to help them write their code, auto completing the code. And it was finding that it didn't help them at all. And it was, in fact, making things harder, especially for experienced coders. So that's kind of interesting. I think we're going to find that there's positives and negatives all over the place as the technology develops. Okay, so some good examples. The one that I like the most with people who have experienced stroke, who have executive function, there's a lot of cognitive aids out there. Things like scheduling reminders and note-taking applications and to-do lists that have like an integrated AI. I've used so many, but like Todoist is an example where you start typing or you start typing on your phone what activity it is, and then and it will like autocomplete and kind of read what you're writing, like meeting with so and so at the cafe at 2 o'clock, and then it will generate the location, the time, the meeting reminder, all of the aspects that you need to put it into your calendar. And so these are really important for folks who have a challenge integrating that information and remembering it. And it's like auto reminders of like, hey, time to go to that meeting. Note-taking applications, things like transcribing live transcription using AI, super, super impressive. I think one of them is I was at a conference and every speaker had live closed captioning, and it just is very impressive, particularly for people with disabilities, and having that live written feedback, and to be able to focus and, depending on the disability. And to-do list is the same way, like it can auto generate and it can do all these, like learn your habits and your behaviors. And there's lots of different applications out there. Writing aids, another example. So for clinical documentation, that's one thing that's coming out. In the OT world, OT Potential, which is a podcast, just released a blog post about all the different documentation tools and like the top 10 tips of questions to ask yourself, like when you're using AI related to note taking and clinical documentation. And so sometimes it can be really helpful and sometimes not so. And so being able to understand the like potential pitfalls is really important. Academic, I already kind of talked about that. Journaling, there's some great AI journaling that can help, be a mental health tool to help organize your thoughts, to help students with different aspects. But with using any of these large language models, you always want to proofread and edit because there's no guarantee that it said anything. In fact, oftentimes it makes things up when you're looking for more specific science-based things that's been found. Some examples of tools that I really like include Goblin tools, ChatGPT, SciSpace, Elicit, Site, Research Rep. These last few are really specific, and often the first two can be done free. The last handful often have like a trial period or a limited number of generations. So like SciSpace will write your like you type what you're writing, what paper you're writing, and it will help you write the sentence and frame the sentences. I don't like using them when it comes to citation generation and like thought process and all these things, because it costs money, and I'm not quite there in accepting it yet, but I know some folks may. Um, I like Ask PDF because basically you upload a PDF of like a journal article and then you can have a conversation with it. So you could say, and it basically anthropomorphizes the paper that you put in. And so I think it's really great for students who maybe have concept, like maybe different types of learning disabilities or different kind of comprehension issues. And so it can help kind of reframe and recontextualize papers or different aspects. And I think it's just really a neat idea to have a conversation. Like I would like upload a book and have a conversation with a character from a book. That would be really, really cool. So those are just some examples of different AI uses in the context of clinical care or research. So here's a picture of Goblin Tools. Goblin Tools is my favorite. It was designed by a person from the UK who I believe self-identified as being on the autism spectrum. And so basically it's a handful of tools to help. And this magic to do is like one of the key things in the OT world of breaking down tasks, like task analysis, like making it step by step. And you can make it like as complicated or as simple as possible. Like how to make a peanut butter jelly sandwich, and we'll step by step make you a list. The formalizer will take language, like written language, and change the words into more formal speak, more angry, like add emotion to it for folks who are having difficulty with written word and emotion, especially with emails. That's a big challenge for a lot of people. Judging is like taking emails that you've gotten and it'll tell you the tone so you can interpret it. Professor will teach you about a topic. I tried it out and it's not the best, but it's okay. Estimator is like I want to clean my closet. How long is that going to take? And it will estimate how long an activity will take, which I know is again a challenge for some folks, especially with executive dysfunction. The compiler will take like a brain dump or like a journal, like you want a journal, and it will make like bulleted lists of the things that you said and the thought process that you had. And then Chef is really great. When I don't know what to make for dinner, I'll put in like the things I have in my fridge and it'll give me like a dozen recipes on what I have, which is great. Great, great, great. So then that's just an example of an AI tool that I really enjoy. Okay, so moving on to another example here. I think I only have a couple more slides. But one of the virtual pieces of technology, and again, we're experiencing it right now using this software Zoom. But Project Echo is a formal organization of experts where they have dozens of different Project Echo subtopics in the medical world, and then there's a handful of ones related to allied health, interdisciplinary, and but basically the concept of Project Echo is to have a virtual meeting of experts and clinical level clinicians. And so it was originally created for rural New Mexico, where there's a doctor in a rural town who needs support on a patient, and so they'll present an anonymized case for the first half, and then a second half is it's the other way around. The first half is like a presentation on a topic, so a didactic lecture, and then the second half is a case, and then everyone kind of discusses the case. It's very relaxed, and the idea is to develop this network of experts that you feel comfortable talking to, and you can share and spread knowledge and expertise, which I think is great. This is another example of doing it. These happy hour, virtual happy hours, virtual webinars are another way. The Project Echo is specific though, because it's a regular meeting where you meet and you learn and you get to talk with experts. And I think, like I said, we have eager clinicians to learn and become the experts here. And there's a lot of knowledge to be spread. And so I like to say it kind of democratizes knowledge, like makes it freely available. And it can be personalized too, which is great, to a specific topic. Like if you wanted to do one just on stroke and interdisciplinary stroke at, some specific level, like whether it was rehab or outpatient or both, or the transition between one to the other. I mean, that definitely could be created. So that's another good example. So how do we meet people where they are? That's the title of this. I think the key is to not think of it as being a virtual version of the in-person one, of how we standard do it in a standard way. I think it's using new technology and using these unique innovations in a way that can help best support our client, our patient, the people we care for. And so we want to utilize new techniques, especially in this post-COVID world. We are all a lot more comfortable than we used to be with these virtual meetings. And that's just kind of what I mean in that context. Like the comfort and the familiarity with the technology has actually really bolstered people's willingness to engage in this way. And at the end of the day, I think people will see the value of it when you can reach someone who is in New Mexico, who's like a 3-hour drive away, who needs care, and we can provide it virtually. So I think that's my last slide. Thank you. Question time from those who are listening in.
Okay, I have one. Can you hear me?
Yep.
Okay.
Yes.
So I think I find one of the biggest challenges is kind of like what the next step is after you finish these studies, because the whole implementation piece, and you alluded to that when you talked about telehealth and what to do next. My research right now is not with people with stroke, it's with different rheumatic conditions, and we develop these virtual programs. But first, people have to be referred to OT, at least with stroke. Usually people have had OT or they have some idea about it. But it's kind of like, how do you do that when it's, like yours was a 10-week program, ours have been 6 to 5 weeks. But how do you, and mine are a group program. So, it's like, it's not reimbursed. And how do you, what suggestions do you have to try and it's they're all telehealth. So, that's another aspect of it. Any suggestions? We're wrestling with that.
Yeah, I mean that is a challenge. I think approaching it from a regulatory standpoint and a research at the same time is probably the key for reimbursement. And so at least with OT interventions, and I know APTA and ASHA also have these people who go to the federal level and advocate for different services, but making it, I mean, I honestly think that the best way to go about it is if all three professions, have the same message in terms of telehealth reimbursement. And then they can be like, hey, look at all these studies that have this effectiveness. And, I don't know if it requires comparison to in-person standard care versus virtual, like what measurement needs to be in that study for, and a regulatory body to be like, oh, this is worth it. I'm not sure, but advocating and supporting, and that's like kind of the only road I know of. But yeah, I definitely think it needs to be all of us together to have that big voice.
Yeah, I agree. And I think you also said the fact about it, it makes it accessible to a lot of people like stroke who may not be able to come somewhere
Mm-hmm.
due to transportation issues, or they live rural or whatever.
Yeah, exactly.
Okay, thanks, Tim.
Yeah. Any other questions?
I have a question. I was just curious. Well, I have a couple of questions, but the first one is regarding the Magic to Do page that you showed.
Yeah.
I was just curious how you see somebody with stroke using it. You kind of talked to it from your perspective, but I'm just curious how you would use it, like in a treatment session, or if you were doing therapy with somebody with stroke. How do you see it being used?
Yeah, I think introducing it as a tool that's possibly be used. So, you have a client who's having these issues, identifying the challenge in their task or whatever they're facing. So, if you can use it as almost like a cognitive exercise, be like, okay, we're having trouble prepping lunch. I'm just gonna use OT examples. And so it's like, this peanut butter jelly sandwich, or like making lunch for me and my family. And then, you use it as an exercise. So it breaks it down and you can identify, well, let's imagine doing this activity. What would be the challenge between step A and step B and steps, B and C? And then where is the hardest part on this? And so I think having our patients and our clients identifying the challenge in this process is part of it. So like identifying what the issue is, and then apply that approach maybe to other things that they have challenges with. And so I can easily see someone using this a lot at first, maybe. There's a phone app version 2 where you could just pull it up on your phone and, you're like planning your day or your week even. And using the estimator to be like, oh, it's going to take this long plus the travel time. And so this tool can help kind of guide that process. And so as the therapist, we can provide the structured interaction so then they can take it and run with it and use it, as a tool through their, whatever challenge they have, like executive function.
Great, thank you. I do have one more question, and it's just thinking about for somebody going into this area, maybe, and I'm coming at it from a research side too, but for someone going into technology enhanced interventions or maybe just technology enhanced treatment, are there any lessons you've learned along the way that would be helpful for either a clinician or early stage investigator as they start thinking about integrating technology into interventions or treatments for people with stroke? Just any lessons learned that.
Yeah. Okay. So I think that it's I think one of the slides I alluded to this, but like when thinking about the stroke population, thinking about, well, how can the person that I'm working with access this technology? I think that's the biggest thing. So can they interface with it? And is there solutions that will overcome whatever challenge, whether it's a physical challenge, say someone's hemiplegic and you wanted to use a phone. So, maybe having a mount or a place to put the phone so with their intact side, they can interact with the phone. Instead of maybe, using both hands to interact with it. So that's just like one solution. So there's like lots of things that it could be language issues with aphasia. It could be the cognitive issues. And so like having solutions to overcome for your intervention, that access part I think is really important. And so and then also things like scheduling and timing and having wiggle room and flexibility with all of those things, especially with research studies. And then I should build on top of that. On top of that is just like the person's comfort with technology. Like maybe the person just doesn't want to use that technology, and that's important data to gather, to report, but at the end of the day, they're not going to fully participate in intervention, and you may need to, have them not be included in their study. So just being understanding of what is required for the technology and in relationship to the person. And so, you can make it very person-centered from that regard because you're designing it so for them. And I think it's important to also report when you write up the study. It's like how much tailoring needed to happen. And if you integrate it into your study, then it's already part of it.
Great, thank you. Are there any other questions? Monitoring the chat. Not seeing much come through, but I think Dr. Dionne would be happy to share his contact information if you have other questions. And I am going to take the screen back for a minute here.
I can stop share.
Okay. Okay, perfect. So I just wanted to take this time to thank you, Dr. Dionne, for your presentation. We really enjoyed learning about technology and how it can be used to support people with stroke during rehabilitation, and also thinking about it from the provider side as well, and also a research standpoint. So I want to take a moment to just briefly remind everybody about the ACRM conference that's coming up at the end of October, beginning of November. So if you haven't yet, please look at registering and attending our conference. Aside from that, you may want to consider joining our stroke interdisciplinary special interest group. And we have lots of different task forces looking at all of the different elements of stroke rehabilitation. And we have several different projects going on, and we're always recruiting new members. So thank you, everyone. This concludes our episode for today. And be safe and stay healthy. And we hope to have you join us again in our next webinar. Thank you.